This
Hello?
conference will
Hello?
now be recorded.
Hello?
It told me, huh?
I can hear people. Can you hear me?
Yeah.
Okay, good. Okay, so I just hit record, so here we go. All right. So the reason we are here today is to talk about schizophrenia and schizophreniform disorders. We've touched base on bipolar disorder, and so this is a logical segue to other things we're talking about as well. So there is a handout that I did. It has not been put on Bamboo though yet, I'm afraid. I didn't realize Bev was gone. So that will be available for you. So I'll just start right off the bat. So schizophrenia, I know for a fact that you guys deal with it a lot in the community. And it can be an extremely hard illness to manage because it's often coupled with a lot of other things. So the DSM-5 made some changes with regards to schizophrenia, and they broke it down into three things. They broke it down into schizophrenia and the different types, and there's paranoid type and some other types. And then they said, put in a label of the schizotypal personality, which we'll talk a little bit about because it's important to talk about that because it doesn't quite meet full criteria for schizophrenia. And then the third one is schizoaffective disorder. And when we were talking about bipolar disorder, there was some, I wouldn't call it confusion, but there can be some hesitation in really understanding the diagnosis because it looks like bipolar disorder with psychosis. Schizoaffective disorder, and they're treated differently. So we'll look at that. So schizophrenia, there's different what they call domains for schizophrenia, and there's 5. The first one, and it's related to symptomology. So the first one is delusions, at a present part of the illness. And delusions are fixed beliefs that are not, that reality and the outside environment do not support. So also one thing to think is that a question to ask the client if you think that their belief is delusional is what evidence in your immediate environment is present that would support that thought. And then that will open it up for a discussion on whether or not those 2 or 3 or 4 or 5 things can really be linked to support those beliefs. So the other thing to look at is in talking with the client, are those beliefs changeable and are they amenable to change? You'll get an idea of not only a person's insight, but the level of how fixed the delusions are if you ask questions. So that's the first domain is delusions. The second domain is hallucinations, and very commonly people think of hallucinations as hearing voices. So the 3 primary types of hallucinations are auditory, where you hear voices or sounds, things approaching can be some of the sounds. And then there are the visual hallucinations, where you may see, very commonly, there may be shadows. And a lot of times this can contribute to a person's paranoia because they may think that someone's coming up on them. Or so shadows are very common. Sometimes visual hallucinations involve people who have predeceased the individual. If there's religious context to delusional thinking, it can involve spiritual entities, biblical entities, things like that. So it can be quite expansive. So the third is olfactory, and olfactory is hallucinations related to smell. Now, the most common olfactory hallucination is smoke or fire. And the research goes back many, many years and supports that as the most common olfactory hallucination. Why that is, it really has never been fully established. Backing up to talking about people who predecease the person, sometimes there will be smells of cologne, cooking, a musty type of smell based on the environment, things like that. So, but the most common is smoke or what could be perceived as ignited fire. Okay. So that's the second domain, is hallucinations. The third domain is disorganized thinking, which you're only going to really know about through the person's speech. So we're going to link a few. So in disorganized thinking and speech, you're going to have loose associations, what they call loose associations. Loose associations are talking about topics as if they're related, that may be only vaguely connected. For example, the fact that a person ate breakfast and then went to a job interview. Okay, the two don't seem connected. However, eating breakfast helps the person feel better so that they think they'll do better at the interview. So that's kind of a looser association. So when you think about things in context, think about things in context of how it's ongoing in a linear way, as well as how it presents individually in the environment. So that's an example, I think, of breakfast and a job interview. Loose associations could also be related to symptoms like paranoia. So if a doctor is assessing a change in medication and the person has a level of paranoia, they may just consider or say they're considering possibly it's a chance that the medication change is because of perhaps the doctor's dislike for them, or because they missed their appointment last month, or things like this. So they have concerns about the rapport with the psychiatrist, could be separate from the medication change or could be incorporated very loosely together. So the next one under this domain is tangentiality, and that has to do with thought and speech as well. Tangentiality is running of speech and conversation. So it's the type of thing where we joke and we say, I can't get a word in edgewise, but if you listen, the conversation is not often linear. So it's not often on one topic. It'll be excessive related to a topic, and then it could switch to the next, or it could switch to the next level. And so an example I can give you, just a very basic example that I think of, is if a patient comes to the hospital or goes out into the community. Let's say they come out into the community and their property is packed up and it's coming to the group home. Okay, there may be something within that property that's very important to the person. So they'll start talking to the case manager about, I made this in OT and it turned out really good and it's in my property. And then they get anxious because what if it doesn't make it to the group home? What if it breaks in the box? And then nobody's going to see what I did. Nobody's going to believe that I'm good at anything. And it just goes on and on and on and on. And it's very hard to say, whoa, stop, let's back up. And it's very difficult to try and validate the person within that and to stop the progression, because it's related to anxiety. It's related to, the ongoing, the disconnected, almost loose connections with the thoughts. And so that is definitely something to be aware of. Medication can help that, which we'll talk about. Monitoring anxiety level with any symptoms of schizophrenia is really, really important, because the person does have the personal experience and the connection to the personal experience that things are not aligning correctly according to the outside environment. The third one that hasn't been used very often, but that was used very, very often in the beginning of my career was word salad. And you may have heard word salad. Word salad is in the cases where someone's thinking is extremely disorganized due to the schizophrenic illness. Connections are not being made. So it's a rambling and which the content is words that are completely unassociated. And the context of the statements, the context of the attempted conversation is often difficult or impossible to figure out because it's just grasping at words of different tenses and different contexts and verbs and nouns and pronouns and names. And it comes together, and in the person's mind, they're trying to connect all these different pictures at the same time that are concrete in themselves, but that do not connect. So they may be having a hallucination related to them being bad. And they also may carry the delusion of being more supreme spiritually themselves. And so they will try to connect those two when actually the messages are often opposite. So it won't make much sense. And you might mistakenly believe that the messages are related, that are being given are actually the delusions or vice versa. And it's hard to explain because it presents just very frenetically and it presents extremely disorganized. And the word salad is really the descriptor that best describes it, because it's all different things together that are independent of one another and really unrelated. So questions regarding that, absolutely, I will try to answer because I know that's a tough one to kind of even wrap my head around. So the next domain is disorganized, what's called disorganized motor behavior. And so we're talking about physical expression and behavior. So the most severe on one side of the spectrum is catatonia. So in catatonia, it's like somebody flips a shutoff switch and gaze becomes extremely fixed. Often the eyes will stare and show little ability or connection to focus. They may seem somewhat glazed, and you can almost feel the disconnect. And looking but not seeing, if that makes sense. The person will typically be fully nonverbal. The person will be non-reactive to stimuli around them. So it can be noisy. There can be a lot of people. There can be people giving them prompts, staff giving them prompts or making supportive statements and gestures and maybe presenting something in front of them, a food tray. There will be no response to that. Of concern is that there is often no response to stimuli, including physical pain. So if a client is in a day room in the hospital, which I've seen in a catatonic state, and they may be approached or assaulted or pushed or I don't know at what level by another patient. Say, for example, a patient attacked them and a bone was broken. Staff can separate the two, but the person not only will not communicate that they've been harmed, but may not feel physical pain related to the injury. And that's a very, very real thing. And it's extremely dangerous because many times if someone is catatonic and they're in a public area like a day room or a cafeteria or something, when they enter this state, or if they're in, say, a day room and they're in catatonia and the staff just feel they're better left alone, any attempts to move the person readjust the person. If injury takes place, you're often not going to know it. And that is not only a huge risk, it's a huge liability, and the injury can escalate very quickly. And I've seen that happen over the years. So it's a very, very real thing. So that's just a piece on catatonia. There's more to it than that, but that kind of in a nutshell is what that might look like. The other motor behaviors that I've seen and that are documented, for lack of a better word, a category is called like a childlike silliness. And it's mannerisms that children have that might be attention seeking or to get a gaze placed on them. Things like disorganized motor behavior, in that they might be in line for cafeteria and everybody's walking down the hallway, and then the person may get distracted and become kind of disoriented to the process of going into the cafeteria. They may see a staff they like and run and touch the staff and giggle and run away. It doesn't have context to the present situation, and it's extremely childlike, and it's a behavior like, look at me, look at me. And so it's not an intentional attempt to say, take your attention from other people and put it on me. It's just a very childlike impulse. So the silliness, it can take so many different forms. I've seen it almost exclusively with females rather than males. Males, when I've seen it, it's more of the playground type behavior that you'll see with boys on the playground. They might run and push each other, or they might flip somebody's hat off, or things like that. Take somebody's hood on a sweatshirt in one particular incident that I'm thinking of and put it up on someone's head and then run away. So it's going to present differently, but I've seen it more with females, and it's documented more with females. And a lot of people aren't aware of that little category. So also within disorganization and motor behavior is unpredictable agitation. And I don't necessarily mean assaultiveness. What I mean, it could be restlessness, physical restlessness, restlessness with an emotional type expression like tears, or distractible eye contact, or pressured speech, or very soft volume or loud volume speech. So it is not, when I say unpredictable agitation, it is not always directly related to assaultiveness. And in fact, that is probably the minority of the expressions of it. So pay attention to how a person just is presenting atypical of who they are, or at all not like who they are. If you see something and it just seems out of context, it probably is. It probably is, and it's connected to something. So it's hard to, as busy as we are, to observe something like that. It may be very easily dismissed. Oh, they're just kind of having an off moment today, or something just wasn't right, or maybe I didn't see that right. But it's really, really important to pay attention to those, because they can link to other things going on and other symptoms. So keeping in mind that with schizophrenia, that link can be to things that are very reality-based in the environment, not reality-based or connected to reality within the environment, or a combination of the two. So if there is for an example, if there is a conflict with a staff, yet I am paranoid that someone's going to kill me, then I may associate that staff wants to kill me. Okay, and I need to be kept safe, or that staff needs to be fired, or I need to avoid that person. And so the conflict was probably very real. The delusion was not supported in reality, but the two connected. So there's actually three components to that. You know, what is supported by the environment, what is not, and the connected aspect that can come from those two. So, and then we talk about the next domain is called negative symptoms. And negative means, less than zero often. So if you think of zero as kind of a baseline, and negative symptoms are symptoms that have less outward expression. Positive symptoms such as hallucinations in response to hallucinations. Very often you're going to hear someone verbalize that. Delusions, you're going to hear verbalization of that or see active physical reaction to engage in the content of the delusion, avoid the content of the delusion. So it's very active, and often it's visual or auditory. With negative symptoms, the opposite is true. There's going to be a decrease in emotional expression. There's going to be a decrease in the motor behavior often, and there is going to be a decrease in either the tendency or the ability to engage with others. And so that's why they call it negative, because it's less than or it's without the engagement on all, outward levels that positive symptoms would be, if that makes sense. So some examples are real diminished emotional expression. Something very upsetting may happen, and there's just kind of a numbing or almost a disconnect where the full association to the situation is not made. Pairing with that is diminished physical movement. So the person is going to very likely do less, just do less physically. Increased sleep, which is called anhedonia, is very, very common in someone with negative symptoms. And excessive sleep, a recommendation that I just really believe in when someone comes into the community is sleep logs and symptom logs. And by symptom logs, I mean symptoms of affective behavior and symptoms of the illness. So a log may start and it'll say it's just check boxes. So it's very easy for the person. It may say slept well, did not sleep well, but then how many hours? Took meds, did not take meds. Cried, did not cry. Talked to a support person, did not. And it's just a checkbox, and it's an inventory that's done daily, usually at the end of the day. And it gives a very, very clear picture of what is going on. You can hand it to a psychiatrist, and they think they're beautiful tools. They tend to think they're beautiful tools. So couple that with a sleep log and keep track of how many hours per night there's sleep and when it is interrupted. So keeping a pen and a worksheet by the side of the bed isn't going to disrupt sleep too much if a person wakes up. Of course, an overhead light is going to do that, but a book light may not. So it's important to see where the gaps are and to just talk to the person. And often that's going to be more the role maybe of the case manager initially to bring it to the attention of other providers. And then the psychiatrist can talk about, well, what's happening within those times that you're awake? What's happening? What kind of sleep are you having? Are you dreaming a lot? Are you falling out of bed? Those kind of things really do play a part. So the third area is regarding social interaction, and it's called asociality. That's how it's written in the text. And basically what it means is diminished social contact or lack of social contact. So traditionally where someone may have peer connections or a connection with their case manager or a connection with their providers, their family, you're going to see a change. And it's not an aloofness. It's not an attitude of I don't want anything to do with you. It's just a disconnection from and a withdrawal toward their self. And it's a form of isolation, but it's more an internal isolation that can be present as well as a physical separation. So for example, in contacts, the person may meet with the case manager just as frequently as they always have, but the verbalizations are less or the answers are shorter. So open-ended questions are huge. Because for someone who's starting to withdraw and become more asocial, a close-ended question is a dream. And an open-ended question can instill anxiety, so they want to avoid that. So open-ended questions that are fairly concrete and very targeted are really important. Also, expressing a concern to a person about, wow, you're being less social, or you're sleeping more, or you seem flatter, you don't seem as excitable, or those observations can be made, but it really is, you're going to kind of meet a dead end if you try to really engage in a conversation about it, because it's contrary to what negative symptoms are, being symptoms. So keep that in mind. That's really important. So schizophrenia is a thought disorder, and so that's why antipsychotics are used. Age of onset in females is typically mid to late 20s. Sometimes you see it in the early 30s, where with males, late teens to early 20s is very common. And college age is very, very frequent as a time of onset. Sometimes a significant stressor will kind of pivot somebody into their first psychotic break. And if a person who has a tendency toward this or a predisposition toward this is in college, the pressure of college can often throw somebody into psychosis. A client I had attended UW-Stevens Point. He was a football star in high school. He did not make the football team at UW-Stevens Point, even though he was in line for a scholarship at the time he left high school, and he had his first psychotic break. And that was the stressor that opened that door. So with schizophrenia is much more frequently diagnosed in males than females. And women are, women tend to carry so many more diagnoses than men. And I can't say for sure what that's related to. The documentation and the research, attribute it to emotionality of females, that therapists and psychiatrists and psychologists tend to look at more options of what it might be with women because they express more emotion. I don't know if that's true, but it is much more commonly diagnosed in males. So treatment with antipsychotics for schizophrenia, the first generation antipsychotics, top three: Thorazine, Prolixin, and Haldol. All three are still used. Thorazine is probably the least used of the three. All three of them have extremely high side effect profiles, both long-term and short-term. And so side effects with those three are fairly unavoidable. You're going to see the muscle stiffness. You're going to see the dry mouth. You're going to see the sleepiness, the sedation. You're going to see weight gain. Those are the big four. You're also going to see other things. You're going to see maybe white blood cells change, or the quantity of red blood cells change. It depends on the medication. So now more frequently used or more widely used are atypical antipsychotics, which are the newer ones. So ones that I typically think of are Abilify, Invega, Risperdal, Zyprexa. Those are very commonly used. There are many others, and there are more and more medications coming out every year. And unless a person has a direct link to training, you'll never be up on all the medications. There's just too many that are being proposed. The thing of it is that numerous medications come out and then they get in line for FDA approval. And then other medications are meeting the criteria to go generic, so the names change, and people may mistake that for a new medication. So it kind of becomes a cluster. defer to the psychiatrist and the nurse and get education as a case manager or direct care staff about what these medications are, because it can only help. And it can only help the relationship with the client and the care for the client. It's a lot of information. So Clozaril is a medication that I really wanted to just raise because it is used still with the criteria that 3 to 5 antipsychotic medications have to be tried and documented fully with detailed and outlined justification why they did not work before a patient can be approved for Clozaril. And being approved for Clozaril, there are Clozaril programs, which I'm sure many of you are aware of, which include funding for Clozaril because it's very, very expensive. The problem with Clozaril is the mandatory lab draws, and you absolutely cannot go without those, because if a person is not at therapeutic level, they can get very ill or they can physically die. It can be very dangerous. So the blood draws are non-negotiable. That is a reason why many people are not compliant or don't want Clozaril. So the side effects for Clozaril, the 2 big ones that almost immediately show themselves are weight gain and drooling. So one thing to remember about side effects, when we talked about medications a number of weeks ago or a number of months ago, we talked about not only the physical discomfort from side effects, but the social discomfort from side effects. The side effect of drooling from Clozaril is mortifying for people. It is mortifying. Not only being in contact with people and actually drooling, but being in a setting where you drool in your sleep and staff see your bed linens, or you want to change your bed linens more frequently and you're questioned why. And drooling is physically uncomfortable because it dries the skin. It can cause chafing and chapping from wiping with Kleenex, or licking with your lips or rubbing with your fingers. So often there can be almost chafing or abrasions around the mouth, especially here. So it's something to be aware of. It's extremely uncomfortable socially and physically. So that's kind of in a nutshell schizophrenia. I just want to touch a little bit on the schizotypal personality disorder. You don't see that diagnosis very often, but the DSM-5 cited it very clearly. And the reason they did that is because it's going to be showing itself for people who don't fully meet the full criteria for schizophrenia, but they present in certain ways. So symptoms that present themselves often do not respond to medication because they're not the more biological, chemical related symptomology that will respond quickly to medication. It's mannerisms, it's personality features that are reminiscent of it, but are not actually the gene level illness. So just a couple things to keep in mind. People may assume someone is schizophrenic if they gesture awkwardly or if they have mannerisms that are kind of outside of the social norms. And an example of this may be someone who's walking down the street and may just refer everyone physically. And it's a mannerism that comes from almost a physical engagement with the environment rather than delusional thinking. It's just being part of your environment, part of your world. So awkwardness, social awkwardness is huge. And also the inconsistency in social engagement is huge because it can look like negative symptoms of schizophrenia. But it may also be personality features which block social adequacy or which diminish social skills. So there can be a low level of paranoia, but it may be connected to where the person comes from. And the person may express it fully as paranoia. Kind of in an example would be this person hurt me in the past and you look like them, so you're going to hurt me. It's an association that in some ways can make sense through trauma theory, but it can also be an association that can be connected with a schizophrenic delusion, paranoid ideation. So there's really a fine line. The big thing is it does not respond to medication. So someone who is not psychotic, not biologically psychotic, if you put them on an antipsychotic, they can become psychotic. Someone who is not actively exhibiting full connected symptoms to an illness of a psychiatric nature, when you give them psychiatric medications, it can throw them in all different kinds of directions. So that's really, really important to remember. That's why assessment is so important. So lastly, in the DSM-5 is schizoaffective disorder. The very first thing I want to say about schizoaffective disorder is people very commonly confuse it with bipolar disorder, because schizophrenia is a thought disorder. Bipolar disorder is a mood disorder. Schizoaffective disorder is both. It's a disorder of thought and mood. Okay. So a person who presents with schizoaffective disorder, even a physician or a nurse or whoever the provider may be, can mistake it for that person's in a bipolar depression, or they're in a psychotic bipolar depression. They're in a psychosis related to bipolar mania. Okay. Those things can happen, but more criteria is present to fit schizoaffective disorder, including that they will respond to an antipsychotic and a mood stabilizer. If you put someone with bipolar disorder on an antidepressant, it's dangerous. It may very well throw them into mania. Someone with schizoaffective disorder, a very low dose antidepressant coupled with an antipsychotic can be very effective. More so, a mood stabilizer coupled with an antipsychotic can be very effective. So just a couple examples. Abilify and lamotrigine, very commonly used together. Lamotrigine and Zyprexa, I've seen used together. Nifazodone, which is an antidepressant mood stabilizer. It's a mood stabilizer with antidepressant properties. With Abilify, very commonly used and quite effective. Abilify, has the mood stabilization properties with the antipsychotic with the psychosis type stabilization properties. So all different kinds of combinations can show up in the physician's office and in the psychiatrist's office. So that's why. So schizoaffective disorder, the age of onset is a little later. It is also more commonly diagnosed in women than men because of the mood component. So age of onset for males is very similar to schizophrenia, but less frequently. So you're not going to see that mood component with men so much as you will with women. And the research says that some of that is stereotyping of gender. Some say that when a male exhibits emotion, it more often is assumed to be agitation. And so a lot of it is based on assumption rather than hard research facts or preconceptions. So in women, often the first diagnosis given is bipolar disorder with psychosis, very commonly. And it's almost always bipolar 1, which may or may not be the case, but that's for a whole different time. And we're going to be talking specifically about bipolar 1 and 2 at another time. So that may become clearer, I hope, at that time. So schizoaffective disorder being a disorder of thought and mood, the simultaneous treatment with the antipsychotic and the mood stabilizer, I just want to say, is absolutely necessary. So the other thing too that you can see with schizoaffective disorder, in addition to the mood swings, you still see the disorganization. You can still see the negative symptoms. Impulsivity is a big thing. And sometimes you're still going to see most likely hallucinations, delusions. But one thing to keep in mind is that the impulsivity, the mood swings, the agitation may be in response or in reaction to the content of hallucinations and delusions. So that's the added component. And so it takes asking questions and really being observant to see what's going on. As a case manager or provider, whether someone has schizophrenia, schizoaffective disorder, or schizotypal type features, clarity and communication is huge. And by clarity, I mean clear messages and conciseness. Because if I am suffering from schizophrenia and I have auditory hallucinations, I may hear the first 5 words of what you say and then think of what's going on in my head. Or I may hear the first 5 words of what you say and connect that 4th word to something in my delusional thinking if I'm not stable. So extremely clear and concise is huge. The other thing is predictability. The best way to combat paranoia is to instill predictability and structure. It won't get rid of it, I'm sure. And there's so many different contexts that paranoia can be present, but it's extremely helpful if predictability and structure are in place. The other thing that's very helpful with paranoia is consistency. So presenting congruent to the environment, consistent to the situation each time by a provider is going to increase the reliability and can challenge the paranoia. It's not necessarily going to quell the paranoia, but in the person's mind, it may cause them to question whether that delusion or paranoia is valid. It's likely not going to disappear, but even if you have that small window, that's a huge opportunity. For that person and for you as well. So, and thinking about whether it's schizophrenia or schizoaffective disorder or personality disorder or borderline or any of the things that we talked about previously in these in-services, the most important thing is kindness and compassion. If a person feels that you are compassionate to their situation, even if they know that you don't understand what's going on with them, it's going to go so far. The connection and the consistency between providers, case manager, probation agent, psychiatrist, without that connection and that communication, treatment outcomes for someone in these categories is compromised as far as being positive. The positive outcomes are compromised because there's so much going on at the same time. So we need to talk to each other as providers. We need to get education as providers. And we need to keep our eyes and ears open and involve the client and ask them what their experience is. Delusions and hallucinations are extremely scary. They're extremely scary. And so keep that in mind as well. So, okay, so that wraps up this part of it. And